Good afternoon to everyone. We have about 30 seconds before we officially start. But if you would go ahead and place your name and campus in the chat, ensure that your name, first and your last name appears as it does appear on the roster. Okay, so we'll call it official start time. So good afternoon to everyone. Hope everyone is doing well. Again, just make sure you place your name and campus in the chat and make sure that your name appears how it appears on the roster. You may have to change it if you're logging in on a different device. And as always, these sessions are recorded and they are viewed by the attendance administrators. If there's for any reason that you have to not be in front of the camera, because the expectation is to be on camera unless we're on break. So put a message in the chat to myself. You don't have to send it out to everyone. That's the reason why you're walking away from the camera, restroom or whatever it is that's going on. All right. So you all did well again on exam 2. Be thinking about those things that have helped you thus far, test taking tips, the amount of time that you're spending with the content, because it doesn't end there. We still have one more exam, and we're going to pull up the modules here in a moment. But then you also have those HESs. So today, you have not started going back looking at all of your information from week 1 up to this point. Go ahead and start doing that, because all those HESs, especially if you're taking more than one class, fall in the same week. And it is campus specific. So you might end up with 2 on the same day if you're taking more than one class. So go ahead and start prepping for that. It is not too early. It's sort of like discharge planning begins on admission. So go ahead and start it now. We're not going to wait until week 11 and start preparing. So let me go to the other thing is homework grades are on. And there is a detailed announcement with that, because sometimes there's a confusion when we turn it on and when we turn it off, because sometimes it does make your grades look a little bit different. So let's go to that announcement first. We just leave them on for a little while so that you can see the effect of them on the other grades on your overall score. Let's see here. Getting it to pull up. We'll just take the time to look at this together. All right. So homework grades are turned on. So what does that mean? Your total grade in Canvas will reflect both your key graded assignments and your homework grades. They're combined. Will be able to see how your homework grades affect your overall grade. So why is this important? To successfully pass the course, you must achieve that 78% on key graded assignments and a minimum of 78% on overall course grades without rounding. Even if it's 77.77, it must be that 78% without rounding. I know this sounds repetitive, but it is information that you need to know and understand. Your overall course grade will include your homework. Homework will not be included in your final grade unless you meet that first 78% with the key graded assignments, and then the homework is factored in. If your total homework points bring down your overall grade below that 78%, you will not pass the course. So what this bullet point is talking about, if you have 78% outright without rounding for your key graded assignments, but then we turn on homework scores, and those scores that total that average, it brings your grade down under that 78%, then you can still fail the course. So, it's really important that, you keep both grades way above, shoot for that 80%, 85%. And then remember, we do have the HESI. It is week week 11. And so remember that percentage that it actually counts. Remember, you can fail the course if you do not do your homework, or you score poorly on those homework scores. So remember, in the event that you think that you're going to be late with assignments, you should be sending an email communication prior to that, that date that is due. Even if it's the date that is due and you realize something's going on, send that communication. You can still turn that. You still have that 7-day window with that 10% deduction. We think about your next exam, we will look at it. If you need that exam proctored on campus, we do need that 72-hour notice just so that we'll have everyone in place and a person that will proctor that exam. Just throwing those reminders. To successfully pass this course, you must achieve that 78% on your key graded assignments and that minimum 78% overall course grade. Failure to meet any one of these requirements listed in the syllabus will result in failing the grade for the course. Let's go to our modules. I may have to stop sharing and reshare because it's moving kind of slow. Let's see. Maybe this will help close up some of these other tabs. Here, let's see. Okay. It's pulling up now. Share my screen again. All right. So we were just in week 6. We just took, unit exam 2. We are in week 7. We'll be looking at, the different healthcare settings that you all have been looking at and experiencing those in live by doing your clinical rotations. But we'll do a deeper dive into those different healthcare settings and what they call quality assurance, how those things paid for. We do have your assignments, and then we have week 8, which we start looking at the theorists and evidence-based practice. Of course, your assignments at lesson activity, your adaptive quiz. And then we have week 9. So we meet today and we meet next week. And then let me look at that. Yeah, that doesn't, I'm thinking about Thanksgiving. Thanksgiving on Thursday, so it doesn't affect us, but that's that week of Thanksgiving, which is week 9, which we have that unit exam 3. And then we will have week 10. That's where you all present your projects. And then tests are in week 11. So we are over halfway. So, like I said, just encourage you to continue to be thinking about what it is that's helping you be successful with your content, those different test taking strategies. It doesn't stop. It doesn't even stop with the HESIs. You have to, you're going to take that NCLEX. And we've been getting great news from the past class. So far, we are, I think, 21 for 21, or has it moved up to 22 to 22? So the work that you're doing, the time that you're spending invested in you and your future, it's going to pay off. But yeah, so right now, and I forget which campus it is. It's 100% pass rate so far. It was 21 or 22 when I looked at the last email. So it is possible, and you all have been putting the work in, and you can tell what your exam scores. All right, let's see here. Again, for those that are just coming in, make sure you put your name and campus in the chat, and make sure that your name appears as it appears on Fortis' roster. So let's go back. Let's look at chapter 14. Then we'll go back and look at a case study, and then we'll look at our other 15 and 16. Okay, let's go ahead and look at these healthcare settings. So you all have been experiencing the healthcare settings for the most part with your clinical rotations. Hopefully you have been asking the questions, having conversations, so that you can decide which setting, you think that's going to best work for you. And then know that it might change once you, get to the end, the final end. But it's time now to start thinking about them. What tasks are required, what's your responsibilities in those different settings, and what's your opportunities as well, because different settings, and I think we kind of talked about this early on, different healthcare settings, some might offer you certifications within that setting. You might can't use those certifications anywhere else, but within that setting, and if you have that certification, then most of the time that adds to your incentives because you're that person that's certified to do whatever that task is. And so here, this table just shows the different pay sources for the different settings. So you do have governmental, and then we have those voluntary contributions. Okay. And then as you have went through your different settings, you know, you see the difference between, how they're just focused on what their focus is. For example, I know some students rotate through like the different health departments, department agencies, and they have all those different wellness programs, pretty much everything from A to Z, cook healthy eating, women's programs, men's programs, children's programs. What was the thing this summer about drinking water? They have all these different disease prevention and wellness promotion programs. And so they get that information from that evidence-based information, and they create those programs. And within those settings, you can have the opportunity to take part in helping put those programs together, package them, and then they roll them out. So know that the opportunities really are unlimited with healthcare is in reference to nursing. So you do have your official, which are government agencies that are nonprofit, tax supported, accountable to taxpayers and government. So that's how those businesses, and that's how they operate, taxpayers' monies. And again, like we just said, disease prevention and wellness is mostly their focus. Because if we can prevent an illness from happening, that's what we want to do. And then we want to keep people well and have them to be able to, if disease happens, then we want people to be able to manage the disease process and be well. And so we and with that we offer some direct services, and some of it is education, where we go in and reinforce that education. Well, they'll come into day programs. Sometimes you'll have the opportunity to go into the homes. I know we talk about home health, but there's some of these programs where it's disease prevention and wellness, and you go into their home, but it's not necessarily home health. And so we talked about this fee for service. I want to say it was the week before last, how whatever the service is, for example, person needs an MRI or lab, then what they can have that service, but there's a specific fee that must be paid prior to that person getting that service. So you do have research and education. So I don't know if you all have several hospitals in your area, but if you notice, for the most part, students, whether or not there's doctors, nurses, respiratory therapists, they pretty much go to those same facilities because those are those teaching or those educational hospitals. So they're the ones that, embrace us and get us in there and allow us to, put into practice, so serve those skill sets that we have acquired. Okay. Again, this is another one on public health agencies. The official healthcare agencies at the local level is city or county health departments. These agencies, they usually have, the following characteristics. They're funded by their local tax monies. They carry out those state laws, those mandated programs, and they carry out non-mandated programs, such as those health promotion programs. We do know, like, this is flu season, so they may have where you can drive up and get your flu shot, drive up and get your pneumonia shot. And so I know when they did the reconstruction of most health departments in our area, they do have the drive up area that's really a drive up area now. I know during COVID, they created those drive up areas. They went back and renovated. And so, all day long, you're doing that health education and you're administering those IM injections. So they offer that, especially at the beginning of, flu and cold season. That would be one of those big programs that they'll roll out. And then in collaboration with other government agencies, they respond to community health issues if there are outbreaks in areas. So it used to be that someone collects all of this data, and determine whether or not there's an outbreak, because area can have a certain number of disease processes occurring. I know the latest thing I saw was maybe like something on measles, but there's someone, they're a healthcare person, part of the healthcare team, might be a nurse, then they collect all this data, because remember, certain disease processes are reportable. So we would go to that state's health website to see the diseases that are reportable. So we're reporting these things, and that might be one of your tasks depending on what setting you're in. But there's someone on the other end of that report, and they gather this information. And what they do with it, once those numbers, there's a predetermination of what is considered an outbreak or a pandemic, as you know, we experienced a couple of years back. But once those numbers get to be that number or more, depending on what the disease process is, then they do call upon the government agencies in those communities, community health departments, to they collaborate and they go out and see what is going on because they want to try to control it. Because if not, you will end up with, a pandemic, endemic, a large number of people, that will acquire that disease process. And so that is a characteristics that you might encounter if you're working with in this type setting. I know was another one that a couple of years back, it was tuberculosis. There was a high number in a specific area. And then they collaborated, and the government agencies, healthcare agencies that came out, there was a mass testing. There were even incentives because, you want to get that disease process under control because otherwise, it can lead to, death and just a large number of people with residual after these disease processes have run their course. So it happens. There's someone looking at those numbers, and if that's the setting you decide to go to, just know that that's what you might end up doing. A bunch of testing, TB skin tests, administering those and reading those. And then the other example was flu vaccines, pneumonia vaccines. So each state has a health department. It's funded by state tax money again. It sometimes receives money from federal government. Some depends on what the programs that they're trying to roll out. Some of those monies will come from the federal government to help those programs be able to roll out, whether or not that's supplies, whether or not that's staff salary, or whether or not that is, what's the other thing, to pay for like the place, like if they don't have those drive up where you can administer those flu shots or whatever, they may have to do, buy a space or rent a space just so that these activities can take place. And so sometimes the states might not have all those funds. Depends on what has happened in their state. If they've had a large number of outbreaks, then they may have utilized all those funds. And then so where they get the money from, you don't want to just let the people just, continue to get the disease process without trying to help or mitigate or stop or control or contain them. So then the federal government steps in and helps out. So official government agencies, official health agency at the federal level in the United States is the U.S. Department of Health and Human Services. And it's funded by federal taxes. Agency's head is appointed by the president. Has 11 operating divisions, including 8 agencies in the United States Public Health Services. So the settings you all are just there. I know for the most part, we go to the nursing homes, we do the home health, we do the rotation through the hospitals, and we do all those different settings. We may even do some of the mental health agencies, but there are so many different settings and different areas that you can work in. So the United States Food and Drug Administration, what's their purpose? They oversee the foods, the medications, even the medical devices that that people can use. They oversee and make sure that these things are safe for us to consume them and to use them. What about the stents the person just got inserted into their heart vessel? Well, the FDA, they oversee that. They ensure that who's ever making, whichever manufacturer that's making these devices and things are safe, and they have to submit all this evidence, information, are safe to use. And once they find out, hey, this thing is no good, it's harmful, then that's when you will see like the recalls. But the Food and Drug Administration, not only do they oversee and ensure that foods and medications are safe, but also medical devices. The CDC provides leadership in health prevention and promotion programs. They are on the other side of that reporting those reportable diseases. And they respond and they activate and say, hey, initially they'll send those notices out. Hey, we're seeing a large number of occurrences of this, measles, chickenpox, or whatever it is. And then in the event that that state or that area can't get it under control, then they may have to actually come out and assist with efforts in getting people tested and offering whatever treatment is available. So the National Institutes of Health, we talk about evidence-based information. So the National Institutes of Health oversees that biomedical research. They have their own laboratories and universities and hospitals and the private research institutions. And you may have some in your area where researchers are trained. They promote those research projects so we can get the latest information on what's the best practices for whatever it is. Heart attack, what's our best response for hypertension, what's the best response for diabetes, and the list just goes on and on and on. There's so many research projects out there, but that's part of how we get our evidence-based information. And the NIH, National Institutes of Health, consists of those 27 centers, and they have that nursing research as part of it specifically as well. There are some research projects that even states even share. So states will get together, or whoever those PIs from those states, they'll write whatever the research project is. And for example, there could be a mobile examination unit. If several states have gotten together, that mobile examination unit can go into each of those states and collect the data. And the data is usually published. People can see, the participants usually see the information that they've gained. And scientists, they'll come up with solutions, whether or not it is, let's just think of doing blood draws, and they're looking at red blood cell counts for whatever it is. And then once they gather all that information, is published, they see what the findings are. Were there any, then they decide whether or not, were there any processes that should have been followed differently? You put your hypothesis out there. Was it true or false? Were some things that we gain any additional information? Did we get any new knowledge, or is everything still the same? So that's a whole different area too of where you might be interested in working with research. But you'll more than likely be gathering data. Even with the research, they even have some where they do phone calls. They call the participant, ask questions. They have these preset of questions. Have you been in the hospital in the past year? If so, was it related to, we'll just say, diabetes? If it was, what was it? Was your blood sugar high or low? How many days did you stay there? And so from that information, then they gather, interventions. And we have the latest evidence information from that. So we do have voluntary, non-official healthcare agencies, American Cancer Society, American Lung Associations. And these are areas too that you can decide to work at. They employ healthcare professionals of pretty much everyone on the healthcare team. But, their focus is specific. It might be where the Cancer Society is trying to raise funds. You may be on the fundraising team. You may also be where they are trying to get people tested for a certain disease process, or could be that they have a resources available and they're trying to find out whoever has it, and so that they can let them know about the resources available. Because it's rarely that people don't want to take care of themselves. That's a rarity. It's that people don't know that the available resources that are out there. And a lot of these American associations and societies, they have so many resources that people just don't know about. So those are some areas too that you might want to think about working in. If you have a passion, or you call to work with people that have hypertension, cancer, and then even with those, there's specific types of disease process within that overall overarching heading. So we do have private healthcare agencies, and these could be for-profit or non-profit. We talked about the fee-for-services, and their focus is curing the disease and illness, and then, having that person to be back to the optimal level of health as well. The goals are usually the same, for private healthcare agencies and governmental agencies. Promotion of wellness, prevention if we can. So family practice physicians deliver primary care and refer specialists if additional evaluation is needed. So you have that doctor that you see all the time, but then, for example, if you need special foot care, and I'm not sure with the changes and everything, I'm not sure if referrals are needed for certain Specialists, you need foot care, so you'll be sent to that podiatrist. If you need eye care, specialized eye care, then you'll be sent to the optometrist. And so, but they collaborate, and right there in the middle is usually the nurse. They're usually the ones that's coming in and reinforcing what the doctor has said and kind of setting up those appointments and things like that. So private practice nurses are advanced practice nurses who counsel individuals that healthcare teaching on healthcare issues. They feel an acute need in rural areas where physicians are sometimes difficult to obtain. So you will see, and you all may have even gotten some notices. People want you to come work. They know that you're graduating. They want you to come work in their area. It could be an underserved area or area where there are not that many healthcare professionals there, physicians. And what we're seeing too in those areas where the doctors come from, especially the specialists, the podiatrists, they'll come to the areas maybe like twice a month. And so that's a way that they're opening up their services for people that live in rural areas, so that that they don't have to travel 2 days or a day to get those same services. So they are making themselves available in the communities. We're seeing that a lot now. So then we have the types of hospitals: the community hospitals, the non-federal psychiatric hospitals, and federal government. We do have general, then you have specialty. You have your level 1s, 2s, and 3s, depends on what's going on with you. Some hospitals, they will, and when you've done your rotation through the ER, you may have seen, well, where they have diverted, they be on diversion. They're sending, telling people, the ambulance, when they call in, they say, hey, we're not accepting, go on to the next hospital. Or if a person gets there and they have assess them and they realize that they need a certain specialist and that hospital does not have that specialist, they'll transfer that patient on to another facility. Because even though they are a hospital, they usually get the patient stable and they transfer them, because if they don't have that specialty there for them, then why would they keep them there? So they transfer them out so that they can. A lot of times it's like bone doctors, orthopedics. Sometimes, you'll hear that, we don't have an orthopedic on call right now, so we're going to go ahead and get you where you need to be so we can get those bones mended. Voluntary community hospitals. Community associations and religious organizations operate voluntary community hospitals. So only thing that is saying is these are the people or the organizations that donate the funds that keep these hospitals open. It doesn't mean that in order for me to go to that hospital, I have to be that religion or I have to belong to that community association or organization. It just means that that's the reason they exist, is to support that hospital in their funds. So that's how that hospital buys their supplies, is how their staff is paid. They are just there. That's how they operate. And it's a good thing that they are there. These nonprofit hospitals provide short-term inpatient care for people that have acute illnesses and injuries, just like the others. The only difference is they get their funds because they're not in business. They're not for profit. They're nonprofit. So they get their funds from people that decide to donate. And so they are heavily dependent, like 99% dependent on those gifts and those donations. And so they usually have a board of trustees. And so sometimes they will even have some of the staff on the board, on some level of the board. So just know, don't pass up those opportunities. Get in there, give your opinion and your information that and because they're looking to provide that best care for their the patients that come in. So again, you don't have to be that religion or belong to that organization to go get those services that they have at that hospital. If that's the closest hospital you're next to, go on in. They're going to provide that best care for you. So federal or state government public hospitals include veterans administrations. The VAs, they're only in certain places. I know in our area, so it's not one in every county, but they are available. And so and they do have like the programs where their patients can get the medications delivered to their home. They can go pick up. They do have some special programs regarding healthcare services and things that their patients can receive. That's the Veterans Administration or the VA. Hospitals for people with serious mental illnesses continue to be funded by federal, state, and county funds. They all share paying those bills, having the supplies, having their staff. So that's what that's how those hospitals are, how they stay open and are able to function. We talked about the teaching and research hospitals already. Like I say, for the most part, the facilities that we go to do our clinicals, those usually the teaching and research hospitals. Sometimes, I mean, we can go to any of them, but usually they're known for, being ready to have the students to come in, no matter what the profession is. They're the training sites for us and our students. They usually, though, conduct the clinical trials at these facilities also, if they have those facility clinical trials. And clinical trials can be anything from testing out a new medication, gathering weights and heights. It's just so much information out there dealing with research, because it's the information that we get to decide what we should be doing. It guides our day-to-day tasks, the things that we do. How do they know at a minimum a person needs to be turned every 2 hours, without, so that person won't receive any tears or any altered skin integrity. This information has been gathered. Okay, so we do have critical access hospitals. They usually are smaller. They usually have no more than 25 inpatient beds. And then they're located mostly in rural areas, at least 35-mile drive away from other hospitals. And there was something else new about the critical access hospitals. Was talking to an administrator of one. I think they were not this at first, but because of whatever the new mandates that came down, I guess the definition changed or the requirements changed, and so like they're in a rural area and it's small, but they had to change their status to a critical access hospital. And so it's based on that mileage, how far you're away, and a number of inpatient beds. There was something else that she said. If it comes to mind, I will let you know. But this was a new thing, because before, I forget what status they were. And so again, they're trying to provide the best care. So they go back and look at policies, what services that the hospital can provide, because usually, if a hospital is 35 miles away from the city, and they probably don't have as many specialists there as the larger hospitals. So then the services that they're able to provide, are limited. So we would need to transfer that patient on out. So ambulatory services located in private outpatient hospitals, even at your bases, they have the ambulatory services there. That's another setting that you can consider working in. You got your Air Force bases. They have their clinics inside, and they provide an array of services. I don't think you all do rotations through there, but start looking at the different settings outside of the ones that you have rotated through, and see if they might be of interest to you. Look and see what their mission statements are. What will be your required task. In a lot of those ambulatory care settings, you do a lot prior to sending that person to that hospital to receive that acute care. You can do a lot in those facilities, because they have more supplies, equipment, and everything than the traditional doctor's office. So they're like a go between the doctor's office and going to that emergency room. But nevertheless, if they can't provide that level of care that is needed, they transfer you on out. So outpatient clinics provide follow-up care for clients after the hospitalization. So this is a place you just know that, you're going to see different people every day. It's not going to be like at that traditional doctor's office where you're going to see, that same patient pretty much comes in probably every 3 to 4 months, to make sure to check on their status and everything. These outpatient clinics, it's pretty much people are just coming in, just making sure that, if they came in for a surgery, that follow up, and, pretty much as long as they're good, you probably won't see them anytime soon. But nevertheless, it is needed. It's a different setting that you can think about working in. Manage disease on ambulatory basis for those who do not need to be hospitalized. Again, it's like that in between. Part of healthcare facilities they are freestanding. They're not attached to the hospitals usually. Appointments are needed. They do include specialty areas such as diabetes, neurology, allergy, and oncology. And oncology is another area where we've seen too, they're specialists where they are, they're located in the larger areas, but then they are offering days of the month where they go to the rural areas and make their services available to the people that live in those areas so they don't have to travel. So that's a good thing. And I think they have separate staff. So, but then that's something that, if you decide to make that specialist offer that service where they go into other areas outside of their main area, that could be something that you could talk about, you know, traveling to their other office or managing that other office. We do have urgent care centers. They are everywhere now. They're so convenient. In the doctor's office, for the most part, they've extended some of their hours, but for the most part, they're closed. Usually, doing those hours when emergencies happen or near emergencies where a person don't want to go to the hospital or really don't need to. And then, but they still need some healthcare services. So what happens is, they go to the urgent care centers. And I don't know if you all have rotated through urgent care centers, but that's a setting. A lot of times you'll be administering medications, PO, IM. You may even in these settings put in Foley catheters, straight casts and things like that. And then some urgent care centers, what we're seeing trending too is that is where some people, they just go get their routine care there. They like the staff there so well, they just go there for their routine care. So that's like a kind of a hybrid model that they're offering. But for the most part, you just go get whatever taken care of. So your doctor's office might be closed, and you don't really require going to the hospital. You go to that urgent care center. But that's an additional service that I've been seeing too. What patients have been saying, well, my doctor's at the urgent care center, which is fine because they're helping them manage their care. So you have the 1-day surgical care centers. I don't know if you all got a chance to rotate through those, but that's a setting. And then you have the free clinics. They're alternative means of providing primary health care. And then what we are seeing in our areas too, we have the free clinics. They don't call them, they actually have a name, whatever the name of it is. But, they don't, require a fee. You can come in. Now the services might be limited. You're not going there pretty much getting, stitches or things like that. It's just that routine care. You may go there, get your blood pressure managed, may do blood work, write your prescriptions and things like that. And if you need specialty care, they usually, refer you out. And so they do require, and usually these free clinics depend on donations and things as well. But you see this, some of the same doctors that have their own clinics that works in the hospitals, they also provide their services in these free clinics. And there is one clinic in our area where everyone there is a volunteer. They're nurses that work at other places, they're doctors that work at other places. They come in and they provide these services. That's just part of their volunteer, them giving back to the community. And so just know that the opportunity is there for you to volunteer, to be there full time, and also to contribute financially to these free clinics. I know a resource that was provided, people that needed help with buying medication. So they had the gift cards, and that's the only thing you could use it for. It was, I forget how the card was made or wired or whatever, but a person can go to whatever pharmacy and pay for their medications. So that is a setting also. Some settings that you just might not have thought about. Now, the skilled nursing care, I know you all have rotated through long-term care facilities. And a lot of them now, they offer like the physical therapy on site, occupational therapy, speech therapists on site, where the people can actually not live in a long-term care facility, but they can actually come in and get that day service and go on back home. But then you do have those that stay there Usually is the 20-day stay, 21-day stay, depends on what kind of insurance they have. And they provide that skilled care. Now, the skilled care is, we do have to document, the services that we're providing and the outcomes, because there's a nurse that looks at this documentation. That these are settings or things or tasks that you might not have thought about. But who looks at this information that we're putting in these computers, that we're writing down and documenting? But there's someone, because they have like this, what do they call that? Oh, it just escapes me. But anyways, they look at the care that's being provided, and it's expected, like that person is expected to meet certain criteria to keep receiving those services. They look at, the person's progress, have they regress, the days of services need to be extended? Because sometimes, even though they give that 20 days, you need just a few more days, a little bit more time to spend with that physical therapist one-on-one, or the occupational therapist one-on-one, in order to be able to, manage that condition. So skilled nursing care, long-term care facilities, the opportunities are there. We can be charged nurses as LPNs in those type facilities. Yeah, so this slide goes in a little bit more detail. So it focuses on relationship-centered care, family, client environment. And even if a patient is receiving hospice, they can still be in a long-term care facility. So they don't have to have hospice care at home. And you also are seeing the hospitals have a different unit, even though they're at the hospital, is not considered being at the hospital. So hospice is another service that people can receive care within these facilities as well. And then while they're there, the hospice pays for, the care that they're receiving. Even though they're in the skilled nursing facility, you may have hospice CNAs come in, you may have the hospice nurse come in. They'll come in and provide that patient care at that facility. So alternatives to long-term care, you got home health services. An important role to teaching clients and family is that self-care. You want that client to be as independent as possible so they can get back to their norm, or as close to it as they can. So they can be, as independent as they can. So in the home, we can do skilled nursing care, physical therapy can come to the home, speech therapy, all of those different members of the healthcare team can go to that person's home and provide that care as well. The purpose is to promote, maintain, and restore health or minimize effects of an illness or a disability. Like I say, get them back. If they can't get to their norm, as close to it as we can so that they can be independent. Every person on that healthcare team, it matters. It really does matter. So don't take what you're doing it light. It really, it really does matter. It is important. So services provided and directed by the registered nurse and the LPN provide that basic nursing services under the RN supervision. Teaching, supervising, administering, preparing medications for self-administration. Because remember, we just go in. They're going to be by themselves if they're at home. So we want them to be as independent as possible. Make sure they understand, what it is when it says take 2 of these pills or half of this pill. We might have to make that phone call to pharmacy. If it's a half, they need, for the most part, what they're doing to prevent medication error, they go ahead and send those medications already broken in half, if it's scored. And so that person, it lessens the chance of them over medicating. So administering medications, checking those glucoses, those finger sticks, and whatever treatments, ostomy care, wound care. I'm not sure if they send wound vacs, but they might, really not sure, but wound care and dressings, bowel and bladder retraining. Depends on what that disease process, how long, and what that person has experienced. They may need bowel and bladder retraining. Offer that bedpan or assist to the bathroom every hour so we can get them back retrained. And you look at the schedule and see, we offer it, but then they may not go at 6 o'clock. We offer it at 7 o'clock. They may not go, but offer it at 8 o'clock. Oh, they actually use the restroom. And you just keep looking at what that pattern and see if there's a pattern, because then that gets them back accustomed to, it helps them to not be as incontinent and back to being continent so that it lessens the chances for something else happening, that altered skin integrity. So all of these things matter. Not really sure if you all have done the bowel and bladder retraining, where you go in and offer the, assistance with them using the restroom. So other types of care, community health nursing services, improve health status of communities, groups through education, screening, and care outside of the acute care setting. This is what I mentioned with early on about the health departments. And you have several nonprofit and profit organizations. They promote, um, these services as well. I know it is pretty much, it's all different kinds of things, you all. So there's a nurse that promotes healthy foot care. What does that nurse do? She goes out and she provides the education. She does the foot exam, and she helps those people get their um, diabetic shoes, or shoe that is the orthotics that goes into them, inside the shoes and all that. And it's a service that you usually the insurance pays for, but we don't never really think about it. A lot of people don't think about that part. So there's so much out there with these different settings. We have adult daycare centers, who need supervision, people that need supervision due to physical or safety needs. They're not that nursing home or long-term care candidates, but the family member might work during the daytime, so they just want their loved one to go and be supervised while they're at work. And a lot of times too, the patient themselves, a person themselves, they just want something else to do during the daytime. They don't want like work, get a job or anything. They just want to be interactive with other people. And so you will see those person actually going to those adult daycare centers, because they all have games, activities, they have all those different interactions, they go on trips, they do a lot in those different facilities. Then you have the independent living, the assisted living facilities, the residential care homes for those with occasional mild cognitive and mobility issues, and then that continual care retirement community. The settings are just, I know through rotation, the clinical rotations, you might not experience all of those, but there's so many different settings that you can work in and you would enjoy. Um, Rehabilitation services focus on return of function, prevention of further disability. It is so important that we, follow that plan of care. And once we figure out, notice that whatever that intervention is not working, that discuss it, change it, because we want to get everyone back to their optimal level of care, so they can be as independent as possible. I don't know why I keep saying dependent. Independent. We want people to be able to, provide for themselves. And these rehab services, they can take place in, pretty much whatever setting the person is actually in. Their insurances is paying for, or they might be paying for it out of pocket. So we have wellness centers now. They, of course, promote wellness and detect disease in the early stages. There's a lot of educational programs that are usually come through these wellness centers, and it's everything from A to Z: stress reduction, self blood pressure measurement, monitoring that blood pressure. You have people that comes in and they may do nutritional classes, or they do live demonstrations of how to prepare a meal, looking at food labels. The possibilities they really are unlimited, you all. Okay, so I kind of already talked about hospice, but I'll just go back to the slide again. Available in many areas to persons who have been certified as terminally ill, 6 months or less to live its disease run its normal course. Sometimes the disease process does not run its normal course. There are some people that subscribe and that qualify for the hospice because it says 6 months or less to live based on what's going on with them. There's so many people that come off hospice. They be on hospice for a year or two. It just depends on what the disease process is doing and, that patient status. So of course, no one knows when anyone's going to actually pass away, but this is something that they put in place so that that person can get that specialized care. And their focus is maintaining that comfort and that dignity. And so, like I said, usually the hospitals, you see several hospitals now, they're training to the hospice inpatients. So they're not, is at the hospital, but they're not in the hospital. And if a patient is in a nursing home or long-term care facility, they can still subscribe to this hospice care. Hospice home care is also available to those who wish to die in their own homes. So what do? The nurses and all those healthcare professionals, they go to that person's home and provide those needs. They don't have to be inside a facility. And so with palliative care, provides comfort care similar to hospice. However, palliative care is often initiated at the onset of treatment and can be assessed at any stage of the illness, whether terminal or not. So with hospice, that word terminal is there within 6 months. So while receiving palliative care, the client may still choose to receive life-saving implementations. But usually with hospice care, they decide not to receive the life-saving implementations. Usually they are do not resuscitate, but it doesn't mean that they have to be that. But that's just usually how it is. What the person decides or their healthcare proxy decides for them. But palliative care, that patient can still decide to receive life-saving interventions, and they receive treatment throughout the disease process, whether or not it's terminal or not. And usually they'll come in and you'll sit in on those meetings. There's usually several meetings because that's a huge decision that people have to make, whether or not they want hospice services or they want palliative care. And so we do want to make sure that we're providing all of the information to those patients and their family members so that they can make informed decisions. Maybe it's just be the patient, but the patient might want family members in, whoever's, it's okay to talk to. So palliative care, it can help relieve symptoms such as loss of appetite. They'll work specifically on pain management, and provide help with healthcare decisions, supporting the family members. They'll have, much like the hospice, they have chaplains that come in and speak to the patients. They'll have music therapy, they're all different types of services. Let me stop and see if there are any questions about those different settings. If not, we will go on and do our first little break. Again, if there are any issues with you being on camera, you all have been doing it, but I just like to put that reminder out there because if there's any question, we have it documented that, what you said was going on, because again, these recordings are reviewed by the attendance administrators. So remember those those 15-minute increments and stuff. So just make sure you keep putting that in there and communicate. Did not see any questions. So what we'll do is we're 7 minutes before our break. But when we come back, we will look at that case study, that second one that we didn't look at last week, and we'll just kind of do it together, and then we'll move on with the rest of our content. So we will see you in 5. And just as a reminder, these sessions are still recorded during the break, you all, but you'll feel free to put yourself on mute, turn your camera off. See you. Okay. So last week I sent out two activities. We only got a chance to go over one of them. It's in your Canvas meal. It says 6-2. And it just says see attached. And it says case study 6-2. But I'm going to share my screen though. So we'll work through it together. But those healthcare settings, you all, I hopefully we sparked some interest in some places that you might not have thought about. And so, you'll have time to decide, but just be thinking about those different settings. Okay. Gonna share my screen here. Okay, we're gonna focus on Miss Lewis here. Let's see. Let me share. Then I think we have one more, but we'll look at this one first. Let's see, current slide. Okay. So we have Miss Sharon Lewis, is a 68-year-old female presenting to the emergency department with difficulty breathing. She has an allergy to penicillin. She has past medical history of diabetes type 2, hypertension, and COPD. As you're sitting down getting report from the nurse, the outgoing nurse, or as you are looking at your test questions, you have these scenarios. As you start seeing certain things, certain information to start popping up in your head. Even their age. If this person was 6 years old, 75 or 90, 30, this person 60, certain things should start just populating automatically in your head. Open those files because you all have the information, and start seeing if there are connections, what should be done, what could potentially be wrong with this person. This person's having difficulty breathing. What body system is this? What organs? What's not happening if this person is having difficulty breathing? What is happening? What would be some objective findings? Respiratory rate, it's probably going to be above normal. What would their O2 set be? So some things you should start thinking about certain things. You have to know what a person's allergies are because we don't want to administer anything to that person if we know they have a known allergy. We do know that people can become allergic at that moment in time, but we have known allergies. That's important information. Their past medical history. We need to know this person has COPD. What is that? What body systems does that mostly have to do with? Hypertension. What is that? Diabetes type 2. Okay, so then Ms. Lewis is admitted. She went to the emergency room. She's admitted to the med-surg unit with the shortness of breath. Now we're saying that she has productive cough with yellow sputum. What is the norm? Is it norm for someone to have a cough? Should it be productive? What is the norm for sputum? Okay, and she also has had fatigue. Is this new? Is it a new onset or has this been going on for a month or 2 months? She's had it for the past 5 days. Okay, she reports increasing difficulty breathing despite using her home albuterol inhaler. She lives alone. Why is that important? And has not been eating well. Why is that important? So as you read through the scenario, as you're getting report, you'll be thinking about what the findings are, and what is the next step? Is it important? What does it mean? Okay. All right. So now we have some more information on her. We have her temperatures, 101.8. Is that okay? So normal, abnormal. Her heart rate is 112. Is that normal, abnormal? And as we were reading through the scenario, like I mentioned, going the wrong way. What are some things that if someone's having difficulty breathing, what would that person kind of look like? What would their presentation look like? Which we probably thought that they would be having, labor breathing. They're breathing faster than normal. That blood pressure, 48/88. Their history, they have a history of hypertension. O2 sat on room air, 88%. What's that normal O2 saturation? Okay, are they in range or out of range? Okay, so in the physical exam, we listened to those lungs. What were those objective findings? What did we hear? Crackles in the right lower lung field. Was it on both lungs? Was it upper, lower? It's really important to know all that information. Take the time to do the assessment. Dyspnea with minimal assertion. She gets short of breath. Person gets short of breath. Just moving from here to there, changing position or moving from chair to bed. Productive cough, with thick sputum, appears fatigued and anxious. When we look at this person, what is it? What descriptive terms can we use to describe what they look like? They appear anxious. That probably causes, they're struggling for breath. O2 status then. Okay, so then we get some labs. What's the white blood cell count? What's that norm? Blood glucose. Did they have a history of diabetes? If they were diabetic type 2. Chest x-ray, right lower lobe consolidation. So something's not right in that right lower lobe. That matches what we heard. Okay, and then the sputum culture is pending. All right, so then we get some orders. So which of these can we do? What was expected? What should we be expecting? The person's O2 stat was low. They had a fever. So do these interventions, do these orders match? Or are they solutions? Are they interventions that should be implemented for the person? O2 at 2 liters, because remember, they were on room air. They were setting at 88%. So yes. IV fluids, at 75 cc's an hour. They're getting antibiotics, levofloxacin. That white count was elevated. They had the fever. They're giving this Tylenol. And then we're getting them to use an incentive spirometer. This is a non-pharmacologic intervention. So we want them to continue to try to expand those lungs. So we get them to use that incentive spirometer. We do need to monitor their glucose because they are a known diabetic. And also, they haven't been eating well. So we do need to be monitoring those glucoses. Do we need to give this person a regular diet? This person is a known diabetic. And what's something else that they might would have added to this diet? Let's look back at their history. So they're on a diabetic diet. Let's look and see what else. What they might want to add based on this person's history.
Like a heart healthy diet.
Okay. And what else? What could address someone having COPD and they are having trouble breathing? What about that food that they're eating?
Smaller, more frequent meals.
Got it. Yep. Got it. So yeah. So it seems minute, but it is a big deal. If a person's having trouble breathing, we do want them to still get those calories. This person's a diabetic. We do want them to get those nutrients from the food. So having these huge meals, they're not going to be able to tolerate it. So what are they going to do? They're not going to eat the food. Then you're going to have blood glucose is up and down all over the place. But if we make those smaller meals more frequently, then they're more apt to consume at least as close to normal calorie consumption as possible. Good. Okay, so here's day 2. Miss Lewis continues to have that low oxygen saturation. It did go up a little bit because I think initially it said 88%. It's 89 to 90, despite the 2 liters of oxygen, and shows increased fatigue. So not that much improvement. Her PO intake still is poor. She is coughing frequently. The night nurse notes that she was too tired to even use the incentive spirometer overnight. The nursing student assigned to Ms. Lewis must determine how to adjust the plan of care using critical thinking and evidence-based practice. Okay. So let me stop for just a moment. I'm going to put the questions up and I want you all to respond. And I thought I had that on a single slide. That means it's not going to take but a minute to do this. Let's see here. So we're going to be critically thinking. Okay, share my slide again. I did do what I thought I did. Let me go back to the slide. And from current slide, okay. So assessment and let's go back at the way. Okay, assessment and interpretation. What additional assessment should the nurse perform to evaluate Ms. Lewis' respiratory status? So it seems like we listened to the lung sounds, we checked the O2 stat, and we counted respirations. Is there anything else that we can do to assess the respiratory status? This because looks like she's getting worse. What else can we look at or do to tell us how her respiratory status probably is?
Agitation.
Okay. Know whether or not it's present or not. What else?
Level of consciousness.
Okay. See where she awake, alert. Can you tell me who you are, what your name is, where are you? The purpose is good. What are some other things that we can look at, do or say that can kind of touch? Because sometimes you will have some vital signs. You're like, wait a minute, this person doesn't really look like they're in distress. But we do that focus, more additional assessments to determine, okay, yeah, this person really is, they're in distress. These numbers are, really this person's in distress. So what else? What else can we look at, determine, or assess or ask? Respiratory status. Think about when you're gathering your information, you're headed to assessment. Respiratory.
Any discoloration. Capillary
Got it.
refill.
Got it. Capillary refill, discoloration. Do we see any cyanosis anywhere? Good. Do that capillary refill. Is it refilling less than 2-3 seconds, or is it greater than? Yes. What about the nasal flaring? You can see them using accessory muscles. Okay, this person really is that. Yeah, they're having trouble. They're not improving. How should the nurse interpret the persistent low oxygen saturation? Think about our history.
She has COPD.
Right.
Got it. What does that mean?
That her level of oxygen may not even be above 95%. Her base could be lower than that. And
Got it.
where she's sitting at is just her normal range.
Got it. So that's why it's so important to get that history. It's important to know that she has COPD. And that's why we're going to do that additional assessment to see if she really is in trouble. Doing the cat refill, looking to see if we see any cyanosis, use of accessory muscles, because she is correct. The person that has COPD, that might be their norm. That might be an improvement. But with these additional assessments, we can look to see whether or not this person if they're getting worse or not, or if they're getting better. Good. Anything else we left out, you all, with this assessment and interpretation? Anything else we didn't think about? Good so far. Okay, so now evidence-based nursing interventions. Based on the current pneumonia management guidelines, what nursing interventions could help improve oxygenation and promote secretion clearance? What can we do? What interventions can we
Often
implement?
a deep
Got it. That's good. Good. Coughing, deep breathing. Good. Anything else? You see nurses and respiratory therapists doing
Using
this.
using
tripod
the
position.
thermometer.
And she has a sinus barometer, but she hadn't been able to do that. Somebody else was saying something else. What was the other thing that we can do?
Tripod position.
Exactly. What else? What else? Incidence barometer, cough, deep breathe, positioning. What else? Have you all ever did the little taps on the chest and the back? You just
To
do.
break
Yeah,
up
I've
the
seen that
That's
mucus.
before.
physiotherapy.
Exactly. Got it. Got it. Good. And it seems minute, but those little things, it really can make the world of difference in that client
They
getting better or worse. Go ahead.
they made they starting or they've been doing it, making the beds where they do the little as to interpret like a pattern on the back. They make the
Mhm.
bed do that now. I think that's pretty cool.
It is. It really is. Like, who thought of that? We've been doing it all this time. They create these beds. That's great. And what else? What other ideas will we come up with? You all will come up with things that we've
Wouldn't
been
you
doing.
wanna
Oh,
wouldn't you
okay.
wanna encourage fluid intake too?
Fluid intake. Good. It does help thin those secretions and get secretions moving.
I like warm, yeah, warm fluids probably could
Yeah.
help.
Okay. Good. Turn that water on the restroom. If it gets hot enough, if it gets warm enough to make a steam, but if not, you can do like a warm cloth. That might help. Good, good, good. What evidence supports early mobilization and incentive spirometer use in pneumonia recovery? We kind of touched on that. Using the spirometer, it gets those secretions moving, gets those lungs expanding like they're supposed to. So that person can have that what's the word I'm looking for? So those lungs can really expand like they're really supposed to. But it's another word I'm looking for. So prioritization using ABC, airway, breathing, and circulation. What should be the nurse's priority actions? So let me go back to the little scenario. So here it says that, this is my connection is poor. Are you all still able to hear me? Can you all hear me?
We
It was
can.
going in and out.
Yeah.
Okay, because it said it was unstable. So I'm trying to tell you, I don't know what happens. It just does that. So okay, you're back now. So the question was, using the ABC framework, airway, breathing, and circulation, what should be the nurse's priority action? So now this is day 2. She continues to have a low O2 saturation. Think about the things we just said. Despite the 2 liters of oxygen, she has increased fatigue. She's not eating. She's coughing frequently. She's not even using the incentive spirometer. She's just too tired to use it. So what should be our priority actions? What should we be focused on? A meal intake, that airway.
Definitely the airway.
Definitely the airway. Yes. Okay. How should nursing care be adjusted to manage Ms. Lewis' fatigue while ensuring treatment effectiveness? Excuse me. We kind of talked about it with the meals, offering those smaller meals. Even though we go in and encourage a person to turn to reposition every 2 hours, we may want to go in, every hour, maybe every 30 minutes for an hour, and then go back to the every 2 hours, because we know that moving, getting that person moving around, that can help. So interprofessional collaboration, which members of the healthcare team more than likely is going to be consulted to assist to optimize Ms. Lewis's care? Who do you think they're gonna call in to help us provide care with her?
Respiratory.
Therapist.
Respiratory. Yes, most definitely. Got it. With the meals, dietary. Yes, because for the most part, they have whatever they serve is what they serve, but they also have these alternate options if a conversation is had. Got it. What evidence supports involving these disciplines in pneumonia care? What says we should get dietary involved? What says we should get respiratory involved?
Dietary, because if you're gonna start offering more small frequent meals, then you want to maybe cut down on portions when they're bringing her the food. And then with respiratory, you might need additional layers of medications to open up that airway.
Exactly. Because even though we can, administer the inhaler, the nebulizers and things, we may need them to come in and actually do the chest percussions or administer, some more medications. We just may need them to come in and as reinforcement. Good, good, good. Okay. So that was good. We did pretty good on that one. You all are doing really well. Do bring to all those things that like I said, as you look at their age, certain things you start populating. You should start thinking about. And that's where that next gen, I know I know it's like a bad word to say next gen, select all that apply, but that's where they're kind of getting you to start thinking, because it's rarely one thing that we have to focus on with a person. This person, they came in with a broke leg, but then they also have diabetes. They're also expected to deliver in a month's time. They also have hypertension. They also. So we have to think about all those things, because it's rare that it's just one thing that a person that you have to focus on with a person. That's a rarity. I think I had one more before we move on to our. Next. Okay, no, that was it. Okay, good. All right, so let's move on to chapter 16. Get this one pulled up. Just downloaded. I'm not gonna have to download it again. Okay, maybe it's gonna pull up this time. Let's see here. Okay. All right, so we're gonna look at healthcare systems here. Let me share my screen. And let's do our little slideshow. Okay. So financing, how are things paid for? The services that we provide that we're implementing, that IM injection, that finger stick, that medication. How are these things paid um, for that patient that we're providing that best care for? So the United States healthcare system has been described as a poorly organized and complicated maze of services which lacks preventative care, waste resources, and is very expensive. Medicare changed from fee for service to prospective pay based on diagnostic related groups. Those DRGs, in short, whatever the diagnosis is, they have gathered all of this information that says that the person has a right hip fracture, that this person is going to use this amount of supplies, they're going to need this amount of visits to the hospital, to the doctor's office, they're going to need this, going to need this, and they're going to need this. Based on all of that, for this right hip fracture, we pay this amount of money. And so, but with that diagnosis related groups, even though that person has that hip fracture repair, they may also have diabetes, they may also have hypertension. So you have to list each of those diagnoses. You want to document everything that you're doing for that patient, because then it goes back to, well, how is that facility going to get that money in order to cover the services, the supplies that was provided. And so, like I say, Medicare went from fee for service to diagnosis related groups, looking at all the diagnoses that this person has and what does each diagnosis require. Does it require, 4x4s? Does it require finger stick probes? Does it require a blood pressure cuff? And based on that, they come up with the money that that the facilities will be reimbursed. This payment system extended to include healthcare provider payments, which led to the birth of managed care organizations. So that documentation is essential. So managed care organizations, they provide both delivery and financing healthcare for members, HMOs, PPOs. I know for the most part, we've heard of these acronyms, point of service plans and open access plans. Those all fall under those managed care organizations. The American healthcare system change results, minimize client length of stay, utilization management. So if you talk to someone that gave birth probably 40 years ago, 30 years ago, and someone that gave birth this year, last 5 years, and you would ask them, how long did you stay in the hospital? The amount of time would be really, really different. So the length of stay was a lot longer. Not to say that it wasn't needed, but the length of stay, and then our what's that word I'm looking for? Our processes, they revise policies and procedures and our processes to so that patients don't have to stay in hospitals, without really needing to be there. So that spirit of inquiry, we've asked the question, hey, can we do this differently and use less resources and the patient have better outcomes? So as a result of that, things have changed over time. And as a result of that, the length of stay in hospitals have really, really shortened, because we kind of figured out, this person comes in, they have a fever, let's go ahead and do these things. If they're coming in with chest pain, let's go ahead and do these things. It's like an automatic. that evidence is really guiding what we're actually doing. Inequities in healthcare access continue. It's still an issue. And then not all have access to healthcare, often lacking preventative care, especially for those of us that live in like those areas that healthcare services are not there and they're so far away to get the services. So, it's just not there. And that presents a problem with, not that we don't want to take care of ourselves, but we just, right now we can't take off work 2 and 3 days just to go see that specialist, to return to see them in 3 days or the next week and the next week for them to give us information. So what can we do differently to help people to be able to be independent and provide that best care? So, Healthcare Reform Affordable Care Act, first sweeping piece of legislation to address healthcare reform. It was in 1965 when Medicare was added to the Social Security Act. So that's 65 and older, and there are few disease processes that fall under here if you're not 65 and older. It enhances the access and affordability of healthcare. If you had to see your bill, and for the most part, I think insurances, they still send that little part out that shows you what you would have to pay if you didn't have the insurance. It's like, oh my goodness, who could really afford that? Even if you had the money, like, really, I wouldn't have went to that doctor's appointment if I would have had to pay, $700 to go in and have a conversation about something. I may would have just Googled it. So healthcare is really is costly. Not to say that it's not needed, but it is really costly. So having affordable healthcare, having the ability to select a plan that's for you, because there are certain plans. For example, if you know that you have a certain disease process, you know that you're going to need at a minimum of certain services, labs, X-rays, MRIs. For example, a person has maybe some type of lung disease or some type of brain disease, they're going to need certain services. So the marketplace allows you to go in and select, a plan that was, that fit your situation, where there was not, excuse me, a limit on the number of MRIs that you can get. Where traditionally your original plan would have limited the number of MRIs. Well, you could get the MRIs, but then at a certain point, you have to pay out of pocket. And then, so with the Affordable Care Act, pre-existing conditions were covered. So prior to that, if you had hypertension, anything that was on your record, it was considered a pre-existing condition, and you were penalized for going to the doctor and seeing about yourself. So the Affordable Care Act eliminated that pre-existing condition restraint. Fee for service. It was a traditional method paying healthcare bills. Physicians were paid for whatever fee, whatever service they were provided, whatever that fee, they come up with whatever fee that they should be reimbursed for. Physicians are directly reimbursed for most ordered diagnostic tests and treatments for illnesses. Some insurance companies do not reimburse a preventative or a diagnostic test for early stage illnesses, which this right here, I always kind of, but this right here is, we need to work on this one. Because how do I know how am I going to find out that I have whatever it is if they don't do a test? Okay, I come in with my signs and symptoms, but if they do an MRI, or if they order a mammogram and I'm not that age and I don't have that family history, then I'm going to be, but then I got something going, I have some type of breast abnormality that is found with me just doing myself breast exams. They can send me for a mammogram, but then I have to pay for it. So we have to work on this right here, where there's no reimbursement for this called diagnostic tests for the early stages. So wouldn't you rather catch something in the early stages so that we can seek out resources and interventions that can cure it, or I can manage it better? I would, but the way it's set up, you're penalized for your doctor, your healthcare provider trying to see if there is something there, a disease process that we can go ahead and start working on. So capitation, goal is to keep members healthy for a provider to make a profit. The healthcare services that cost more than monthly fee, the provider absorbs the cost. So the doctor can submit whatever it is, but there's a cap on the amount that they will be reimbursed. But you still want to document, whatever that was done, all the services and everything that was provided. So how clients pay for healthcare services? What about that private pay? Payment directly by the client. If they go in and get labs drawn, gotta pay however much it costs for that lab to be drawn. And some labs these things can be costly, is what the initial slide say. Healthcare can be costly, but I don't know what the answer is, but there's an answer out there. Private group health insurance, Blue Cross Blue Shield. They're offered by employers. Sometimes your employer insurance costs more than what you would, if you were to go obtain the insurance on your own. Sometimes it's a deal, sometimes it's not. Private, individual, non-group health insurances. Premiums are based on that person's health risk and age. So they look at, how old you are, what's your risk. So they look at your height and weight, your BMI. They look at, have you had any injuries? What's your history it actually composed of, and then they just go from there with how much it will cost. So within healthcare insurance, we do have these different terms. You need to know what the difference in the premium, deductible, and co-payments and co-insurance, what that is. So that premium is that monthly fee that we pay just to have that insurance. It's like a subscription. We're subscribing to whatever the insurance is, that monthly fee we can pay. And they offer you the opportunity to pay, monthly every 6 months, but nevertheless, is that monthly fee. Then the deductible is going to be that yearly amount an insured person must spend out of their pocket for the healthcare services before the health insurance policy will begin to pay its share. Okay. And then we have that copayment. The amount of the insured person must pay at the time of the office visit. You go in, you sign in, and they say, well, okay, we need $20, we need $30, or whatever that fee is. That's called that copayment. And then sometimes you do have that copayment with prescriptions as well. Then co-insurance, once a deductible is met, the percentage of the total bill the insured person must pay. The insurance company pays the remainder. It's like a dual, both take turns or pay a part of it. So we have public health insurances. Examples of those are Medicare, Medicaid. Now, who actually qualifies for Medicaid? And then who qualifies for Medicare?
Medicaid is for low income. Medicare is for people over 65.
Okay. What about VHA, Veterans Health Administration? Who qualifies for that?
Veterans, people who have served in the Air Force, Army, and so.
Okay. And then their family members, like if they're their spouses and children, they may qualify and receive services under there as well. So yes, Medicare, federally sponsored, and it helps finance healthcare for all persons older than 65 and their spouses. So have at least 10-year record in the Medicare covered employment, must be a citizen or permanent resident of the United States. And coverage is also given for certain younger persons with disabilities. For example, end-stage renal disease. So this person may be younger than 65 and still receive Medicare if they have end-stage renal disease. I was thinking it was one more, but I did remember the end-stage renal disease. So that person might not be 65, but they'll still subscribe to Medicare. And then no persons denied coverage based on their past medical history, any pre-existing conditions. And then we have the different parts of Medicare. We have A, B, C, and D. Okay, one is in the hospital, one is inpatient, the other one's outpatient. A is inside, B is on the outside. And then Part C, Medicare Advantage plan, is offered by private insurance companies. They contract with Medicare. There's several of them out there. And then they offer that prescription drug coverage along with the other coverages. But traditionally, Part D does cover the medications, the prescriptions. So inpatient, outpatient, D covers prescriptions or drugs, and then Medicare Part C is offered by those private insurance companies, which it covers prescriptions and other coverages. Okay, Medigap, like private insurance is purchased to cover items Medicare does not cover. You can be underinsured because it depends on what that disease process that you have, and the services that you're going to need, MRIs, lab work done. You know, there are sometimes, a lot of times, there are gaps in things that are just not covered. And then a client cannot enroll in both Part C and D if you have a Medicare Advantage plan, Part C, that includes prescription drug coverage, and you join a Medicare prescription drug plan, Part D, you'll be unenrolled from C. So you can't have both when we're talking about the medications. So let's go back to C and D. So C is this Medicare Advantage plan. It's offered by private companies, and it can cover prescription drugs and other coverages. Medicare Part D covers medications offered by insurance companies and other private Medicare approved companies. So you can't have both, is what this is saying. You can't have both. And if you try to subscribe to both, then you'll be automatically unenrolled from C. So Medicaid medical assistance is eligible for families, individuals with low income and incomes and resources. You must meet the eligibility requirements. Medicaid is a cooperative venture that funds come from the federal and state. Federal government establishes broad national guidelines for Medicaid. Each state establishes its own programs, and each state can also decide whether or not they want to receive these federal funds. You know, do that state want to expand Medicaid or not? Undocumented immigrants and legal immigrants who have not resided in the United States for 5 years are not eligible. So it's important to get, that status, because you have to be documented for 5 years before you're eligible. We do have CHIP. It's like the Stand in the Gap, and it's for children. It is under Medicaid. And for this one, the insurance, the coverage is free or low cost. So a person can maybe have just lost their job and they have their own insurance, but they've lost it. And so this insurance can step in. The person can get this insurance for their children, and it can cover them up to age 19. It's pretty much the same. A lot of people, they like the CHIP rather than their employer offer insurances. And there are different programs out there, like, wow, my child can get these services, and so, do the research, educate families on what's available and what they can be eligible for. The continual rise in healthcare costs has resulted in annual increases in health insurance premiums for employers. And that's why I made the comment, sometimes it's cheaper to subscribe to your own insurance rather than going through your employer, because that insurance, it can cost a lot. The ACA requires the federal government to create a process in conjunction with states where insurers have to justify unreasonable premium increases. They shouldn't be just raising the prices just because they can. This is what this is saying. They must justify, give us reason as why. Why is this premium going up for these individuals? Where's your data? Where's your evidence that justifies this rise in cost? Low-wage the uninsured employed in low-wage jobs that are less likely to offer insurance benefits. And then also, depends on how much that insurance costs. If the money I have is going to make, I have to determine or decide if I'm going to buy meal, my groceries, put food in the car, gas in the vehicle, pay for this insurance. I'm probably going to not pay for the insurance. I got to get to work. I got to, get my family where they need to be. We have to eat. So, and that's where the Affordable Care Act came into place, to make things more affordable for people. You can go in and make the selection on your own. Okay. Alternatives to pay for healthcare. We do say that there is Medicaid out there, but there's those gray areas within these things where you don't qualify. Like, what do I do as an individual? And then, a lot of times I will be uninsured because there's this gray area. I may make $2 over where I don't qualify for the Medicaid. Then I don't have enough to subscribe to the private insurance because I just can't afford it. And so what happens? And again, going back to the Affordable Care Act or whatever, specifically that one, to make things more affordable, where I can go in and select what my premiums could be, what my co-pays could be. It just made things more accessible. The prospective payment system, this is a system for reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to provide the care. So no matter if that person went in with that right hip repair, this person also had hypertension, we had to do all these other things. That's this predetermined fixed amount. And that's what the facilities were reimbursed. And so again, you'll see if you're on that quality team, and you may have seen these questionnaires come around, or a nurse comes around and asks these questions of the patient, or when you put that Foley catheter in, you send that first specimen in, they test it to see, if the person has, any bacteria, anything there. The fall prevention. The person comes in because they have pneumonia. We want to make sure these people don't fall, because if they end up injured with a fracture or something that's not related to why they came in, then the hospital, the facilities they're absorbing the cost of that care that takes care of that patient hip fracture, because that's not why they came in, because they have these systems in place that says, hey, we're only going to pay this. We're only going to pay this amount regardless. So I know we got to come up with a solution. So we kind of already talked about the diagnosis related groups. And it was created to, control these costs. But we do want to use, good judgment if a person has a hip fracture. But then they also have all these other things, disease processes that we should manage, and we should provide that best care to them. We're going to just take care of the person's right hip and not check their glucoses, and we know that they're diabetic. No, that wouldn't be good practice. So documentation, getting that past medical history and all that information from those patients, everything is so important that we get all of this stuff documented, because it goes back to that facility getting reimbursed properly. Because if the facility is not reimbursed properly and they don't have any funds coming in, that facility can't stay open. And that's a closed facility within a community. And where are they going to go to get their healthcare services? So it's all really important that we revise policies and procedures, that we document, and we advocate for everybody, including us. So nursing action to improve quality in healthcare. We have improving quality in healthcare, the continuous quality improvement. And you can work on one of these teams in the facilities. What is they call them? But anyways, the whole purpose of them is to improve the healthcare that they're providing within those facilities. Now, some facilities have outright a team of nurses that go in and make sure and see what the processes are and see how we can advise them. They're usually the ones that are teaching new employees when they come in, and seeing if there are any certifications, rewriting policies and procedures for that facility. So be thinking about that if QI or quality assessment is your thing. Improving safety, the Joint Commission National Patient Safety Goals. You all may have been at some of the hospitals when they say JCO's here, they're on their way. And but these are things that are in place so that they've identified, hey, it's a problem with falls in acute care facilities. There's a problem with falls in long-term facilities. What can we do about it? So they create these safety goals so that within all the other care that we're providing, that we will also provide care that hopefully prevents these people from falling and injuring themselves. Another one that I can think of is identifying the patient. Another one is in the acute care facility, doing the timeout and ensuring that you have the correct person for the correct procedure, the correct extremity, and all of that, because it's just so important. And where they will come in, for example, if you're going in to have something done to your liver, on the right side, they'll come in and they'll mark where the liver is and then put a mark, a R for the right side. This lessens the chance of people getting unnecessary procedures done. The person going in to get a right leg, lower leg amputation, and they end up amputating the left leg, the right leg issue is still there. Then you have a person that is missing two extremities. That should not be happening. So they have these safety patient safety goals in place because there have been enough things that have happened that says, hey, we need to bring more attention to this so that we can stop and take the time out to ensure that, we are providing services as they should. No LPN role is containing costs in healthcare settings. It's all of our role. Every person on the healthcare team, making sure that we're providing the services that we need to provide, bringing to attention to the healthcare providers and everybody on the healthcare team, things that need to be revised, goals that have been met or goals that are unmet. Okay, so we have, this one's talking about the never events. So they're serious and highly preventable events. They're, for examples, hospital-acquired infections and injuries from falls. Hospitals do not receive reimbursement for never events. So, because that's the example that I gave, the person comes in with pneumonia and they end up falling and breaking a leg or something. All that care that is provided related to that broken extremity, that hospital is not reimbursed. So that hospital absorbs that cost. So it's important that we do implement whatever interventions, fall precautions, put those bands on, put the non-slipper socks on, provide reorientation, whatever the facilities policies are to prevent those falls and injuries. And then there are rewards for hospitals for meeting and exceeding standards of care. If they have evidence that says a person comes in with a heart attack, you are to administer, you are to do these 4 things. There's a nurse usually that goes back through the records and see if these things were followed. And also to see what this patient outcomes were. Did this patient get discharged? How was this person's status when they were discharged? And as a result of that, that information is turned in and it's like, hey, this hospital, the staff, they are doing what the evidence suggests that they should be doing. And then therefore their patients are having these better outcomes. So readmission reduction programs results in reduced payment when clients are readmitted to acute care hospitals within 30 days of discharge. Somebody keeps up with this. It's usually a nurse. It usually falls under that QA or QI nurse. So they're keeping up with the person that comes in, how many days they stayed, how long did it take them to come back? Did they come back? If they did they come back with the same problem? Because what they're trying to look at is seeing whether or not if the interventions that we're implementing, first of all, did they follow and implement what was recommended? And if they did, and if it's enough of that, then maybe we need to change what we're supposed to be implementing, because things sometimes need to be just revised. It's not enough days for a person that comes in with pneumonia that also has diabetes and also has a right hip fracture. So that documentation is so important. Diagnosis includes acute myocardial infarctions, heart failure, pneumonia, COPD, total hip and hip arthroplasty, CABGs, coronary artery bypass grafts, triggered a strategic effort to improve transitions in care. We talked about that care coordination, that helps with that transitions in care. Talking to the people, the next group of people that's going to be taking on the care of this patient. And we as the LPN, we're instrumental in identifying complications, going back in and doing our reassessments, providing the information. Hey, went in, this person, what we did is not helping or is helping. So we are instrumental in providing that best care for our clients. Okay, so this STEAM, you need to know this right here: safe, timely, effective, efficient, equitable, and patient-centered. So let's make sure we look at each one of these. So under safe, avoid injuries to clients from the care that is intended to help them, keeping those clients safe. Fall precautions, things like that. Timely, reduce waits and sometimes harmful delays for both those who receive and those who give care. Are we able to provide, that's where those nurse patient ratios come up. It comes up all the time in this area. How many patients really can this nurse really see and take care of and provide the best care that they can? Is it okay for one nurse to have 7 patients? Is it okay for one nurse to have 3 patients? Effective, provide services based on the scientific knowledge. This is evidence that we talked about, the NIH, biomedical research. Provide services based on scientific knowledge to all who could benefit and refrain from providing services to those not likely to benefit. Okay. Efficient. Avoid waste of equipment, supplies, ideas, and energy. Can we provide this same services in a different way so this client have better outcomes? That's that spirit of inquiry that I mentioned before. Or do we really need to do all of these steps? Are all these steps really needed? Or are they not? Equitable, provide care that does not vary in quality because of personal characteristics such as gender, ethnicity, or socioeconomic status. We provide the same care no matter if that person comes in every month on the 5th because they're out of supplies, because they've used their money for other things. It doesn't matter. We still provide the best care we can for that client, whether that client's insured, uninsured, or have insurance. It doesn't matter. Patient-centered. We provide that specific individualized care for that client that is respectful and responsive to their preferences. You want to find out what's important to them. What do they know? What are their goals for their care? So these are the aims that guide that the Institute of Medicine they use, and they call it STEEP. Just make sure that you understand that. Improving safety in healthcare. We talked about those national patient safety goals in the hospitals and the long-term care facilities. Usually identification, making sure we have those at least 2 things to identify this person. Prevention of falls. I think falls fall in both of them, the acute care setting and the long-term care setting. We might have a slide on those national patient safety goals. And this is not just isolated to one state, it's a national thing, because we're having high medication or high rate of medication errors. That's one reason why we trained it to the electronic medical records. Even with that, what else and what else? You will see medications packaged differently. Some facilities have like whatever that patient gets at 8 a.m., they have it all in one package. So that nurse doesn't have to go in and read each medication and punch it out or empty it out into the container. You have in the medication, the electronic medical record, where if the medication is past due, where the screen turns different colors. So these are all things that were done. And of course, over time, we still are revising those things because we still have a lot of medication errors. If a person is on the same medication, but they take a different dose at different times, pharmacy usually put some type of sticker or alert on those packages. So it brings your extra attention, even though we're reading the orders and we're matching it up, but it still brings your extra attention to, hey, I need to see what's going on with this. Same dose. Same medication, different dose, different time of day. Oh, and then nurses are often involved in client preparation for surgery and marking the site so no confusion exists during the surgical procedure. Those, a lot of times they call them timeouts, where they come in, everybody stops what they're doing, and they go back through everything. Okay, we're doing the right leg, not the left leg. We mark them. What leg do you say we're going to do, Nurse Mary? We're doing the right leg. Okay, do you agree, Nurse John? So and literally these things are having to be done because there have been so many mistakes that have happened, unnecessary harm to people because, it was the wrong extremity. It was the wrong procedure on the wrong person, because you'd be surprised how many people have the same name or a name that's similar to yours and the same birthday. So it's like, okay, we need to take the time to make sure we identify the correct person. Administering medication safely, reducing. We shouldn't have people that goes in every time somebody goes to that hospital, they come out with, a hospital-acquired infection, MRSA or something. What you got to take the time to use good hygiene, hand hygiene. Okay. National patient safety goals for the hospital. We've talked about these. Use having the 2 identifiers. I think this is the same one also for the nursing home. No, We don't have a slide on that one. But the two identifiers, we still in the long-term care facilities, you'll see different ways that they identify people. They rarely have armbands in long-term care facilities, but they'll have names on the doors. They will have names on beds. They have pictures. They'll have different ways that we can identify. Of course, we're going to talk to the person, but they have that an additional layer, names and date, other than names and date of birth, that we identify who the people are. We talked about safety with administering medications, the reduced harm associated with clinical alarm systems. Now, you don't see these much in the long-term care facilities because what they said is they kind of distort things and make people confused in the long-term care facilities. So you don't see those alarm systems that much in those facilities. Universal protocol for preventing wrong site, wrong procedure, wrong person surgery is a national patient safety goal. And if it happened one time, it's one time to me, but it's happened several times. So the LPN role in cost containment. Follow facility policies for charging clients for all supplies used in their care. They usually have some type of charging system. Sometimes there's stickers you pull off and put on the card. Sometimes you scan it in. Sometimes there's a nurse sometimes that goes back through the medical records, particularly the MARs and TARs, the treatment records, and see they've had this dressing done, this wound care. They've had this, they have diabetes. They've gotten insulin at a routine. They got it 3 times a day. So they use at least 3 syringes. I mean, it goes each supply. Someone's tasked to see what they actually use. Because remember, these things are not free. So facilities have to be reimbursed. So they have to say, well, who's using these supplies? And that might be a role. You might be on that team that helps in deciding and pulling up that information. So, of course, we're working in partnerships with other hospitals, clinics. Remember, I just told you about the doctors coming down to the areas where they're not specialties readily available, working several days of the month so the patients don't have to travel. You're seeing mergers where these larger hospital systems, they are assisting and taking over the smaller system because the smaller system, they just can't afford to run because of the limited revenue and the monies that are out there. It's not that the people don't want to provide the care for the people in their community. It costs money. And so a lot of the larger hospital systems, they are, taking over and helping those hospitals stay afloat so that those hospitals are in those communities so they can still provide that best care. So person plan for change. LPNs must present themselves as invaluable to the healthcare agency. I mean, we talked about all those on the healthcare team, but who's usually in the middle? That nurse. We are invaluable to the healthcare agency. We bring motivation. We're the problem solvers. We're the go-to person. They rely on us to be critical thinkers, to be flexible, and to be role models and identify what needs to be done. Hey, we may need to get respiratory in on this. We might need to have a conversation with dietary. This person's not eating. There's several food options that they just don't like or that they just don't eat. We are the ones that will identify that. Are there any questions? Let me stop and see if there are any questions in the chat. There are not any. Okay, so we're going to go on our next break. We'll return in 5. Remember that these recordings are still playing. And also, when we come back, we're going to put you in your groups and we'll do our group connection and meet. See you in 5. So just give me a few minutes to put you all in the groups, about 3 minutes, and then we'll get back started here. Okay, we got everybody in the breakout rooms. So we'll go there and I'll rotate around to see if there are any questions or concerns, but be finalizing things. This is week 7. We have one more week and then we'll have exam 3. So be revising, readjusting, making those changes, having those conversations. Accept the invitation. Tori and Michaela. Are you all able to join the breakout room with your groups, or is it you having connectivity issues? Tori, are you there? The Institute of Medicine defines healthcare quality as a degree to which health services. It emphasizes that quality care benefits both individual patients and populations, focuses on achieving desired health results and required adherence to up-to-date professional standards. There are 6 core QSEN or QSEN competencies to promote safe, high quality care. This competency emphasizes recognizing the patient as the primary decision maker in providing care that respects their preferences and their values. So teamwork, it is focused on effective functioning within the nursing teams with other healthcare professionals to ensure optimal patient care. You think about all the different services that the client or the patient needs and who can provide those services best. So that's when you're incorporating everyone on that healthcare team, putting everyone in, the dietitian, the physical therapist, whoever is needed to provide that best care. Okay. Core measures are used to track how often hospitals provide recommended evidence-based care to patients with specific conditions. They help ensure that patients receive high quality, standardized care based on the best available evidence. That's that tracking system to just make sure that we're providing the evidence-based standards. OBRA, OMBRA, Omnibus Budget Reconciliation Act of 1987 significantly reformed long-term care by requiring comprehensive resident assessments, such as minimum data sets. You've probably heard of MDSs. This is a role that you can play and take part in working in a long-term care facility. You complete the minimum data sets. And the OPRA, the 1987 Act, emphasized individualized, resident-centered care. It also mandated increased staffing training and quality assurance processes. While hourly rounding and medication timeframes are important for nursing practices, this is not something that the Omnibus Budget Reconciliation Act mandated. It focuses on those comprehensive resident assessments for those for the patients. So we did go over the slide on STEEP, talking about STEEP, safe, ensures care avoids injury or harm to patients, which is fundamental for quality care. Timely, reduces delays in receiving care to prevent complications and improve those outcomes, those patient outcomes. Effective, focuses on evidence-based care proven to yield positive health results. Efficient, making sure that we're not wasting resources, time, money, and supplies while we're delivering the patient care. And then equitable, guarantees care quality is consistent regardless of race, gender, socioeconomic status, or location. And that is patient-centered. That's meaning that we're prioritizing the individual patient preferences. You know, what do they value? What are their goals for their care? What's important to them? We want to include that in there. Quality improvement is an iterative process. If the desired outcome isn't achieved in one cycle, the team should use the knowledge gained to modify their approach. We always evaluate to see if the approach, did it work? Was the goal met or not met? If it wasn't met, we need to evaluate and gain information and then modify our new approach for that new cycle, that PDSA cycle. This is continuous learning, and adjustment is key to for successful quality improvement. Okay, assess what's learned and implement it in the new cycle, that PDSA cycle. The study phase of the cycle involves analyzing the data collected during the do phase. What are we doing? The process in Donna Beaton's model refers to actions taken in giving and receiving care. An example would be implementing the hourly rounding is a direct care activity performed by staff. Hourly rounding can improve patient satisfaction. The patient, sees you more often. It enriches that therapeutic relationship, and it allows us to address those needs promptly, in that hourly rounding. Team Steps is a program designed to improve teamwork and communication in the healthcare. It is created by the AHRQ, that's the Agency for Healthcare Research and Quality, in collaboration with the Department of Defense. The program aims to enhance patient safety through better team performance. This aligns with the AHRQ, the Agency of Healthcare Research and Quality. It aligns with their mission, which is to improve healthcare quality and safety. So they created that Team Steps. Okay. So quality and safety education for nurses, that's that QSIN. The aim is to prepare future nurses with quality and safety competencies. It defines essential knowledge, skills, and attitudes for nursing practice. That QSIN, which stands for Quality and Safety Education for Nurses, focuses on 6 core competencies: patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. These competencies are designed to improve patient outcomes and healthcare quality. The NQF is the National Quality Forum, is a not-for-profit organization focused on meaningful quality measurement. It serves as the central repository for scientifically sound healthcare measures. It has endorsed over 500 measures for use across the healthcare facilities. These measures are used to improve quality of care and support public reporting. Okay, let's talk about professional development. We do have official government agencies. Their focus is on disease prevention and wellness, and are appropriate for LPNs interested in community-based services. Remember that those are where you're out. We talked about the immunization clinics where people drive up and get their flu shots. And there's just so many community-based initiatives. The National League of Nursing aims to lead in setting standards that advance excellence in nursing education. This goal applies to all levels of nursing education, from the LPN to doctoral programs. The organization develops models and competencies to guide nursing education. The National League of Nurses' focus is on meeting the needs of nursing educators and advancing national health. So we are life learners, so be thinking about ways that we can improve or enhance our skills and knowledge to gain more knowledge, to enhance what we know. So a lot of times you might be the nurse, it might be your task, but they have an educational nurse. You might be on that team where they provide those regular unit meeting in-service training. Sometimes they're in person. Sometimes they'll create these packets for people to complete in the computer. It'll be computerized, but nevertheless, participating in that regular in-service training is going to be key in improving and enhancing our skills and knowledge as we are life learners as nurses. A personal development plan shows proactive engagement in personal growth. So they'll ask you to look at these plans or create one initially and to look at them and reevaluate them every year. And it allows for you to set specific measurable goals. And then a lot of times, some facilities, your advancement and also your pay, your raises is based on you creating these professional plans. Okay, we just got a few more minutes. Let me put you back in. What group were you in, Miss Burris? Let me look back at my thing here.
My laptop died, so I just logged back in.
Okay. Well, we're doing our final. We have like 2 weeks until
Into
our
the
group projects. Yeah, so we're just putting our final finishing touches on having those last conversations. Okay, you're with Bruce
and Heather.
Heather.
And,
Okay. Yeah.
Yep.
Where they at on here? Okay, they are in group 4. Okay, we just have about 4 minutes without bringing everybody back. But you should be able to go to group 4 now. So as I was saying with professional development, it's a plan that shows proactive engagement in your personal growth. Taking extra or deciding to, subscribe to or learn more about, we'll just say PowerPointing, or to learn what the newest evidence is about hand washing or hand hygiene. And you bring that information back. A lot of time you have to set specific measurable goals. And then what they're trending to now is your advancement at your facility and also your pay rate. Depends on these plans that you make for yourself and whether or not you meet these goals. The approach, but it encourages self-reflection and continuous improvement. And it demonstrates a long-term commitment to enhancing your professional growth and competence as a nurse. Specialty certification validates expertise in a particular area of nursing. You can go to the National League of Nursing, their website, and it shows you all the different certifications that you can, try to acquire. It demonstrates a commitment to maintaining high standards of practice. Certification often requires ongoing education, promotes continuous learning. Enhanced knowledge can lead to the improved patient outcomes and professional satisfaction. And a lot of times, like I said, you're also compensated for that as well. The Joint Commission, TJC, is an independent, not-for-profit organization that develops and applies standards for quality, safety, and healthcare organization. It conducts on-site surveys, evaluates care processes, and helps healthcare staff improve their performance. The Joint Commission is also a recognized accreditor for CMS Medicare certification. And its accreditation is seen as a national symbol of healthcare quality. Okay, safety is focus is safety. So participation in unit-based council is the first step in shared governance. It helps new nurses become aware of unit-level practices and operational issues, and it gives them voice in decisions that affect their practice. This process supports empowerment, accountability, and professional growth. And that unit-based council is a beautiful thing. Like I said, is a part of that shared governance, and allows us to be accountable as nurses and also to contribute to decision making. They gives you the opportunity to voice what you deem as important. Professional organizations offer valuable networking opportunities with peers. They provide access to latest research, best practices, and industry trends. Many organizations offer conferences, workshops, and continuing education courses, which you're going to need those anyways to keep your members, your licensure up. So by subscribing to be part of that professional organization, not only are you getting valuable information, but you're getting the continuing education units that you're going to need to reapply for your licensure anyways. Membership can also enhance professional growth and care development. Okay, so hopefully you all had time to revise, tie up some loose ends, because we're getting pretty close to the end here. Remember, this is week 7. And so if you have any questions or concerns, you can still reach out to each other on those other means of communicating. And so we will say, have a good night. This recording will be uploaded as soon as I can get it downloaded. Take care, and we'll see you next week.
Heather, are you there?
Yep, I'm sending you a text right now.
Okay. All right. I just wanted to make sure I have you saved in. Make sure I got it.
Yep, make sure you got it. So I went back today to look for a text message someone had, and I couldn't even, I guess I deleted it or something. So I had to send a whole email to say, hey, what's your number?
Yeah, I got a different phone, so it's like all the numbers that I had is just not, I don't know who's who.
Yeah, they say that stuff rolls over.
I put it in our group chat. Did you? And I just sent it. Did you get it?
No. Did you send it to my email or something?
Take care.